So welcome to this finals crash course series on paediatrics. So this is part 1 of our paediatrics sessions, taught by Dr. Valentina Abbey Osman.
Hi everyone.
At the top right of our slide on this, that's our Instagram page. So please follow it, and then you'll have all the details of our upcoming sessions. And on the bottom left is just our email. So if you have any questions about the session today, or any questions at all you want to ask us about any of our sessions, please feel free to email us. And then if you go to the next slide. So this is the link to our VVox poll for today. So if you scan the QR code, then you can get logged in and you can vote as we go along. So I'll just give you another 30 seconds just to scan that quickly. Fab. I think we can probably move on to the next slide. I'll post the link in the chat as well in case you missed it. And I'll hand over to you now, Valentina.
Thank you. So hi everyone. So today I just thought it'd be good to go through some of the common abdominal presentations you might find during your pediatric rotation or even in your exams. So I hope you find it useful. So we'll start off by the first question. Well, this is just some of the things that we'll be going through today. Some of the topics I found were quite that you'd find quite a lot in some of the exams that you guys have. Can everyone see the question?
Yeah, we can see.
Okay. I'm just trying to start the poll, but for some reason it's not allowing me.
Have you clicked the start session button at the top?
Yeah.
Let me log in and have a look.
Things seem. Okay, I think it's fine now.
Is it all right?
Yeah, it's working.
Fab. Let us know.
So yeah. Do you know roughly how many people there are, so then I know?
So we've got 2 at the moment.
Okay, cool. So we'll give about like 30 seconds for each question. Okay. You've got 1 person responding. Okay, so we'll go ahead. Can everyone see the results?
I think just, if you just say kind of what the most popular one was, then that's probably
okay.
This way.
So it was 50-50 between E and B. So if we read through the question quickly, we've got a 4-week-old young male who's been brought in with persistent vomiting over the past 2 days. He was born at 36 weeks and he weighed 3.8 kilos, and he's now weighing about 5.1. The other pertinent information is that the mother says that he's been vomiting more frequently and forcefully in nature, and more recently it's been quite projectile. He's been feeding less, but luckily there's no vomit. There's no blood, sorry. He's still been wetting his nappies, but he's not passed any stool yet today. He's well hydrated. So given the likely diagnosis, what would be the most definitive treatment? So as you can see on the answer on the screen, it says it's laparoscopic pylorotomy, and the reason is because this child is suffering from pyloric stenosis. So if you look at the question, it says what the definitive treatment would be. So the thing that would completely treat the condition, and that's doing a pylorotomy. And in terms of the other response, so 100 milliliters IV, so you would only really do that if the patient didn't appear hydrated. So in this case, the patient is quite hydrated, so that wouldn't be the case. I hope that makes sense. Should we move on to the next question? I'll put the poll up for that. And I've put a timer on as well. Okay, so the most common response that we had was A, which is the correct answer. So again, this is very similar to the previous question. We have this child who is having projectile vomiting, and it's after his feeds. He didn't have any complications during birth, and he is, from the sounds of it, well perfused, so he's well hydrated. There are no issues in that respect. But on palpation of his abdomen, the doctor notices that there's a smooth olive size mass in his left epigastric region. So all in all, that should give you an indication that, again, he's got pyloric stenosis. And with pyloric stenosis, the most common acid-base abnormality would be hyperchloremic, hyperkalemic metabolic alkalosis. And the reason for that is because when you're vomiting, you will be losing your potassium and you'll be losing your chloride. So as a result, you get a metabolic alkalosis with those two losses. I hope that makes sense. Just let me know or write it in the group chat if anything doesn't make sense, and then we can go through that as well. So here's the next question. I'll open the poll for that. Yeah, and the responses we had was E, and the correct answer is also E. Well done, guys. So again, this is very similar question. I just wanted to make sure that we all understood the different ways that they could ask you questions, but also what exactly could be happening. So again, if you look at the ABG for this patient, their pH is 75.51, which is alkalotic. Their potassium and their chloride is also quite significantly low. So again, that shows that he is having, as we had from the other page, a hyperchloremic, hyperkalemic metabolic alkalosis. So that would indicate that he most likely is having pyloric stenosis. But the next question, this is very similar to the other one again, so shouldn't have too many troubles. I've opened up the poll as well. Great. So results showed that E was most common, and that's the correct answer. So we use ultrasound to diagnose pyloric stenosis. It will show you the thickening of the pylorus, the muscle at the end of the stomach, which is indicative of this condition. You wouldn't use any of the other ones. CT abdomen would be too much radiation. Abdominal X-ray wouldn't really show the thickening of the muscle. And urine dipstick, again, wouldn't show anything. He wouldn't necessarily have an infection, and it wouldn't indicate whether or not pyloric stenosis would be present. I think I'm going to leave this question just because it's very similar to the previous one, and we'll just go straight on to explaining the condition. So pyloric stenosis, as we've seen, is a condition that results from the hypertrophy of the pyloric sphincter, which is found in the stomach of all of us, and it typically occurs in children ages 6 to 8 weeks, which we found in the questions, and it's more common in males. So anytime you find males 6 to 8 weeks and they've got vomiting, especially after feeds, think that one of the differential diagnoses could be pyloric stenosis. They usually present with this non-bilious vomiting, so there's no bile, and erectile. The parents will usually come in and say the vomit hits the wall, or it flies across the room. And as it gets more severe, as the pylorus gets more and more, it contracts and becomes bigger, then it's more of an obstruction, and it will cause the vomit to be more severe. Usually, especially after feeding, when they're feeding, you can sometimes palpate this olive-sized mass in their tummy, in their abdomen, and it usually be in the left epigastric region. Some of the complications of this condition would be the hypercholoremic, hyperkalemic metabolic alkalosis that occurs, as well as dehydration. As we've seen, the definitive diagnosis would usually be via an abdominal ultrasound. You'll see the actual sphincter being quite hypertrophied, and the management of this would be by doing a pylorotomy. So that essentially just cuts the inner bit of the pyloric sphincter to create more of a widening, so that the children will be able to keep their food down, and it will be able to pass down to the duodenum. So until that procedure occurs, it's usually really important that babies are nilled by mouth and they are kept on IV fluids. And you only really give IV fluids if the child is dehydrated. So if we move on to the next question, I'll open the poll.
We just have one question in the chat as well, just asking why is it non-bilious vomit?
So it's not affecting, so it's only affecting from the stomach upwards. It's not affecting below the stomach, or it's not affecting the gallbladder or the liver. So that's why it's just going to be non-bilious. I hope that makes sense. Sorry, I can't see the questions. And if I move from this page, then yeah, is that okay?
Yes.
Cool. So we'll move on to question 6. I'll give you guys 30 seconds. Okay, So the response that we got mostly was cow's milk protein intolerance, which is the correct answer. So if we quickly go through the question, a 2-month girl has been breastfed for the first 2 weeks of life before being switched to formula. And for the past 6 weeks, she's been experiencing a number of problems. She's been regurgitating her food. She's been vomiting, diarrhea, and having eczema. Despite these problems, she's still kept the same centile for her weight. And there's no real, the clinical examination is remarkable, and she's, apart from having dry skin on her torso. So yes, the most likely diagnosis is cow's milk protein intolerance. Although you could also say that it could be GORD as well, but because she's had the eczema and the diarrhea, then it's more, and also there's been that change from breastfed milk to formula. It points more towards cow's milk intolerance. It's less likely to be pyloric stenosis because, again, because the vomiting isn't projectile and it's coming with other features that aren't found in pyloric stenosis. It's less likely to be gastroenteritis as well because of how long it's been lasting for. So yeah, if we go on to the next question, I'll just open the poll, 1 second. Okay. Is everyone happy? I'll stop the poll. So we had 2 this time. So it was between extensively hydrolyzed formula trial, and then the other one was refer to a pediatrician. So the correct answer is extensively hydrolyzed formula. So if you quickly go through the question itself, we have a 1-month baby who increasingly has become unsettled, and it's usually around 30 to 60 minutes after their feeds. They have frequent regurgitation and colic episodes, and sometimes they'll have non-bloody diarrhea. There is no history of the following, so fever, urticaria, angioedema, or wheeze, and they're exclusively formula fed. There's some mild eczema in the flexural areas, but their weight remains stable. What would the most appropriate management be? So the first line when it comes to cow's milk protein intolerance or allergy is extensively hydrolyzed formula trial. So that's always first line. And then after that, you may try amino acid based formula trial, but we'll go into that in more detail. Refer to a pediatrician. So only after you've tried both of those and you see maybe that the patient is unstable in their weight, or they have some of the history of fever, urticaria, angioedema, wheeze, and they're just not getting any better, then perhaps you'd refer them to a pediatrician to try and figure out what it is that is causing these symptoms. I hope that makes sense. So cow's milk protein intolerance / allergy, the main difference is that with intolerance, they have an intolerance to lactose, so they don't have the lactase enzymes, so they can't break down the lactose in the milk. Whereas an allergy is they'll have either immediate IgE reaction or a delayed IgE response, and the one that they have will determine whether or not it's they will have it for the rest of their or ongoing, or it will resolve within 5 years. So if it's delayed, usually by the time that they are 5, it resolves. But if it's an immediate reaction that they get, so they get like urticaria, rash, that sort of thing, like diarrhea, vomiting, quite immediately after they drink milk, and then it's usually something that will last longer, till their teens and beyond. That's usually what happens. So in terms of the features, we went through some of them. They usually will be quite colic. Very, very rarely will they have angioedema and anaphylaxis, but it's also really important to look out for. And yeah, diagnosis is clinical. So if they have any of those features, you need to have the assumption that it could be that. And so the way to see whether or not that does have an impact, you would usually eliminate the cow's milk protein by giving them the formulas that we saw. And you would see whether or not that would have resolved the issue. And these the investigations that you see on the page are some of the ones that you would do in order to further clarify whether it's allergy or an intolerance as well. And you want to know exactly what protein it is sometimes as well that's causing it. In terms of management, as we mentioned, so initially if it's, so even though with cow's milk protein intolerance / allergy, it almost always is exclusively towards formula fed babies, but it can sometimes be with those that are breastfed. It's quite rare though. So we'll go through the managements for both. But if it's formula fed first line, we go for extensive hydrolyzed formula milk. And then if there's no response, then we try the amino acid based formula one. And again, so if there's any failure to thrive, that's when we refer to pediatricians. And with the management with breastfed, so you try to get the mother to eliminate cow's milk protein from her diet. And you consider giving her some calcium supplements, because otherwise how would the baby be getting their calcium? And you might use the extensive hydrolyzed formula milk when the mother stops breastfeeding. And the prognosis usually, if it's an intolerance, it usually resolves in most children. I hope that's all okay. If there are any questions, do let me know. We'll move on to question 8. I'll put a timer on for 30 seconds. Okay, so there were 2 responses this time. So we've got reassure and discharge with infant Gaviscon, and the other one was rectal air insufflation. So the correct response was E, and we'll just go through the question. So we've got a 5-week-old baby. His father is concerned because he's had 3 large bouts of vomit in the last 3 days, especially after he feeds, especially when he's laid down. The vomit itself is milky in consistency. Even though he has this, he continues to breastfeed quite well. In the past, he's brought up little amounts of milk. This is known as positing. During the last 3 days, he's had trouble sleeping though, and he's been crying more and arching his back and bringing his knees to his chest. His stools are yellowy mustard consistency, and he has them once a day. There's no signs of infection either. So what would the next most appropriate step aside from examination in management be? So yes, it is to reassure and discharge the infant with Gaviscon. So I can understand why you would think it could be rectal air insufflation. So you might think he has like intussusception because he's bringing his knees up to his chest and he's been arching his back and he seems like he's in quite significant pain. But the vomiting and the history itself is quite consistent with GORD. So we'd reassure and discharge the infant with some Gaviscon, and the Gaviscon should help with the pain that the baby is feeling and help with the vomiting as well.
We just have a request in the chats just asking if you would mind reading out the questions.
Yeah, I can do that.
All right. Thank you.
No worries. So we'll move on to question 9. I'll open the poll. I'll read the question first. An 8-month-old child presents with recurrent vomiting and low weight for their age. On further questioning of the primogravida mother, she informs you that the child was born prematurely, and she has noticed that the child has a chronic cough. The examination is unremarkable. What is the most likely diagnosis? Is it GORD, IBD, whooping cough, celiac disease, or pyloric stenosis? So I'll give you guys 10 seconds. Okay, perfect. So we've got the responses are split between GORD and celiac disease. So the correct response is GORD. And the reason is because so we don't actually have enough in the question itself to suggest that would be celiac disease. So it would be celiac disease most likely if there was a change in their diet. They were having more I don't know, things like barley or anything that has anything that would cause them to have a reaction from within celiac disease, like pasta maybe, or rice. It's more likely to be cough as well, because they've got a chronic cough. So sometimes when you have acid reflux, I don't know if you notice, but you get a cough. It's quite common in patients with GORD as well. And the recurrent vomiting is another indicator. I can appreciate that the low weight might also push you towards celiac disease, but in this question, it's more likely to be GORD than it is celiac disease. I hope that's okay. So gastroesophageal reflux is the passage of the gastric contents into the esophagus, and it's most likely due to the sphincter itself not being fully developed around the time, so around like when they're born till, I think it's when they hit like 6 months onwards, it should be developed, but yeah, prior to that it's not fully developed, and it can cause quite a lot of issues for children. So they'll present with these milky vomits after feeds. They could also present with posseting, which is small amounts of vomits, and they might be quite irritable. They might arch their back and draw their knees into their chest. That's like quite frequent presentation. In terms of management, it's really important to first do things that are non-medical if you can. So with these would be by sitting the baby upright post feeds and make sure that you burp them. So when you put them down into their cot, you try to put them in a slight incline. So again, they're not flat, so that doesn't allow for the vomit to come up, for the milk to come up, I mean, sorry. And yeah, as the sphincter develops and the baby grows, this resolves generally. But there are things that you can use to help the baby. So you can give them Gaviscon in the first instance. And if this doesn't help, then you can give them omeprazole. And then surgically, if this doesn't help, again, you can do what's known as a fundoplication, which is essentially just wrapping a bit of the stomach around the esophageal, the esophagus, the bottom bit of the esophagus, and this prevents the regurg of the feeds. So we'll move on to the next question. So a 15-month-old baby is brought to ED because she has had diarrhea for 3 days and vomiting for 2 days. The mother says she has had diarrhea for 4 times a day, watery inconsistency with no blood. She also has vomited once yesterday and twice today. Both days the vomit was yellow in colour. In the past 24 hours, she's been refusing all food and not drinking. She has had 2 less nappies today, otherwise healthy, and takes no regular medications. On examination, the child appears well and is playing. Her skin is pink and warm with no molting. Her mucous membranes appear dry and her eyes do not appear sunken. Her respiratory rate is 30 and saturations are 99%. Her heart rate is 110 and her blood pressure is 118/78. And her capillary refill is 2 seconds centrally. Her temperature is 37.1 degrees. Her abdomen is soft and non-tender. A urine dip shows no abnormalities. What is the most appropriate management for this child? Is it IV fluids, a diarrhea oral rehydration treatment, IV antibiotics, encourage solid foods, or refer to surgical team? So we have both the responses, and we are split between IV fluids and diarrhea oral rehydration. So the correct answer is diarrhea oral rehydration. So the reason why it would be this as opposed to IV fluids is because although her mucous membranes appear dry and her she's not severely dehydrated, so you wouldn't want to you don't need to give her IV fluids. A diarrhea oral rehydration would be sufficient. However, if this continues even after giving diarrhea oral rehydration, then you would consider giving her IV fluids. The thing with pediatrics is if you can limit the amount of needles and essentially like annoying the child, then you would do that. So anything that limits the amount to essentially anything that would reduce the amount that you would any procedures or anything like that, you would try to limit that as much as possible, and hope that things like diarrhea would help in this instance. I hope that helps. So yeah, this is a case of gastroenteritis. It's the most common cause of diarrhea and vomiting in children, and it's usually because of either bacteria, virus, or toxins. And it's quite common in children because it's very common for them to put things in their mouth and not realize that it's dirty or might be contaminated with one of the bacteria, viruses, or toxins on them. And especially if they're going to nursery, like it's very, very common for them to get this. In terms of with the management, we usually want to, as mentioned before, treat children conservatively as much as possible first. So you would want to replace any fluids lost. So you'd give them oral rehydration treatments. Usually it's things like diarrhea. If it's severe, antibiotics can be used. And these are for those who are systemically unwell, immunocompromised, and in the elderly as well. Specific antibiotics, I'm not sure how much you'll need to know about this at your stage, but they might give you a question on it. So for Salmonella and Shigella, it's ciprofloxacin and Campylobacter. You usually give things like erythromycin. But again, these might change based on what the trust that you're at. They'll have different policies for antibiotics. So yeah. Another thing I want to point you towards that we had to learn is the traffic light system for children. So it's really important that you learn this, even for your OSCEs as well as for your exams. It will show you the level of severity that the child is having with the symptoms that they're presenting with. So you look at their color, their activity, how lively they are, their respiratory function. So whether they're having nasal flares, for example, or they're grunting. Grunting would be obviously more severe. You'd look at their circulation and hydration. So with that patient, they did have dry mucous membranes. That's amber. If it was more severe, then you would consider IV fluids. Other things you would look at would be their temperature, if they've had any rigors, their age, if they're less than 3 months, some of the other things there. And this is what's used to also look at whether or not the patient needs to be admitted, and how much treatment they will need as well. So yeah, just have a look at that. I would say if you can, try and like memorize a few of them, especially for your OSCEs. It does look quite good to be like, according to the traffic light system, the patient is presenting as amber, and then maybe suggesting a couple of them. I found it quite useful for my OSCEs. Here are some of the other differentials of vomiting. So yeah, positing is just simple, small volume of vomits. It's milky in consistency, and it's very common after feeds. Like almost all children will have it. GORD, we've mentioned. And yeah, it can be managed conservatively with positioning and burping as well. Infections, so gastroenteritis, but also other infections like ear infection, tonsillitis, meningitis, UTIs even can cause vomiting, pyloric stenosis as well, as we've mentioned, and if they've had any obstructions, which we'll go on to in a moment, and appendicitis can cause it. So we'll move on to question 11. I'll open the poll. So a 4-year-old boy is brought to the GP because of abdominal pain. His mother explains that he has been complaining of achy abdominal pain all the time. It's worst after meals, and it's better if he eats fruit. He opens his bowel once every 3 days in hard, small pellets that are hard to pass. He's never had any blood in his stools. He eats diet of cereals, meat, and some fruit and vegetables. He had a normal pregnancy and was born to term. He passed urine and stool within the first few hours of his life. He was toilet trained and became continent of urine at the age of 2, but he still poos in his nappies. He's otherwise growing well. On examination, his abdomen is slightly distended, and there are hard depressible masses that are palpable along the left and right sides of the abdomen. What is the next best step in management for this child? So I'll give, okay. We've got both responses. So it's a split between lactose and high fiber diet. So I'll stop the poll. So the correct management would actually be Movicol. So with constipation, which is what this patient is having, the first step would be giving something like Movicol. I believe it's an osmotic laxative. And in terms of why you wouldn't give high fiber diet, that's because he kind of already is having a fiber diet. So he's having some fruit, he's having vegetables, cereal as well. So he's having some fiber diet. It's now going on to a next step where you need to give him something to relieve him from the constipation. So yeah, you would give them Movicol. Lactulose is something you'd give later on. So constipation in children. So it's defined as a child that defecates less than 3 times per week or is having difficulty passing stool. Usually this carpet-like stool that's difficult to pass. They might also have overflow diarrhea. This is more common in younger children, and this is where fluids moves past the hard stool in the rectum. It's very common, and usually it's because of patient's diet, but it could also be because of dehydration, having low fiber diet, not liking to use the toilet could be another one. Pain on passing stool, so it might be due to having an anal fissure, or very hard stools as well, and they might not necessarily also recognize the need to pass stool, which could be another cause itself. There's also some conditions that can cause it that we'll actually discuss as well later on. Something for you to also, oh, sorry. Oh, okay, sorry about that. Something for you to note as well is the Bristol stool chart. Just always important to know the type of the patient is having. So if they're having pellet-like stool, then we know that's type 1, and that means that they're very constipated. And the softer it becomes, the less constipated it is. So when a child comes back to you at the GP, you can ask the parents and say, so what's the stool like now after you've given them treatment? And they can describe the stool, and if the stool's smooth, soft, sausage, or snake-like, then that's indicative of the treatment working. But if it's still presenting as a type 2 or like a type 2 to type 3, then it still might indicate that they're a bit constipated. So you'd want to maybe increase the amount of Movicol that you give, or try something else. So you diagnose it mainly through the history, but you can also, in certain cases, feel the impacted feces when you do the abdominal examination. And if fecal impaction is present, so the first line would be Movicol, and you can use an escalating dose regime as well. And then if that doesn't work, then you can add a laxative after 2 weeks. And then you can a stimulant laxative, like Senna, for example. And then you can substitute a stimulant laxative singly, or you can do it in combination with an osmotic laxative such as lactulose as well, if the Movicol isn't tolerated. And sometimes after initial treatment, some children might need to have a maintenance therapy. So it needs to be continued for several weeks until they're able to establish a regular bowel habit, and then you reduce the dose gradually. So it's really similar to the regime mentioned before. So you start off with Movicol, you then add a stimulant laxative, and then you can substitute that with lactulose or docusate if the stools are hard. Docusate is a stool softener. So yeah. Question 12, I'll open the poll. So you're reviewing a 3-day-old neonate in postnatal wards. The baby has had several episodes of green vomiting. The baby has been urinating every 2 hours or so, but is yet to pass meconium. Baby was born at 41 weeks, and an abdominal X-ray shows bubbly appearance of the intestine with a lack of air fluid levels. Which of the following genetic conditions is likely to present in this baby? Is it cystic fibrosis, Marfan syndrome, tuberous sclerosis, hemochromatosis, Duchenne's muscular dystrophy? So what do we think? Okay, we've got our responses. So we've got between cystic fibrosis and tuberous sclerosis. So it's most commonly seen in cystic fibrosis. So one of the most common things with infants born with this condition is that they won't pass meconium. So this is not passing meconium is known as meconium ileus. So usually baby's first stool is known as meconium, and it's thick and sticky. Sometimes with cystic fibrosis, it will be really thick and sticky, and it can cause intestinal obstruction, and this will prevent them from passing that first stool, which is really important to happen in the first day of birth. It's very, very common in cystic fibrosis, and they will present with not being able to pass it in the first 48 hours, and they'll have signs of intestinal obstruction, so their abdomen will be quite significantly distended, and they might vomit as well. In terms of the diagnosis, you'll do a abdominal X-ray, and it will show this bubbly appearance of the intestine with lack of air fluid level. And the way you treat meconium ileus, or you manage it, is by doing drip and suck. So you give them IV fluids, and you essentially drain the stomach with this tube. And you can also do what's known as an enema. So that will help to remove the meconium, and surgery may be needed, but this is only in severe cases. I hope that's okay. Do let me know. So we'll move on to the next question. A newborn fails to pass meconium after birth, and over the following weeks fails to pass stool unless a finger is passed per rectum. The abdomen is dilated but non-tender. The newborn is not vomiting. There are no other features. This is a typical presentation of which of the following conditions? Is it pyloric stenosis, cystic fibrosis, Hirschsprung's disease, celiac disease, or meconium aspiration? Okay, so we've got both our results. So yeah, so it's Hirschsprung's disease. So the trick to this question is, it says the baby fails to pass stool unless a finger is passed per rectum. So whenever you read anything like that, then you know that it's Hirschsprung's. And we'll go on to the next question. So a 4-day-old baby, a boy, was born at term, has not passed stool since birth. He has an increasing swelling of the abdomen and has been vomiting for the past 2 days. On digital rectal examination, removal of a gloved finger leads to explosive passage of stool. Blood test results are normal. Which of the following investigations is most likely to confirm the most likely diagnosis? Okay. Oh. So the answer is rectal suction biopsy. So well done. And yeah, so rectal suction biopsy is the only one that will confirm that Hirschsprung's is the condition. The others might not necessarily actually catch that it's that's what's happening. So if we move on, so Hirschsprung's disease. So essentially, when a baby develops in utero, sometimes the distal colon isn't innervated correctly, and it results in this aganglionic colon, which is shrunken and isn't able to distend properly, and that is a developmental failure of the aorbac and mesenteric plexuses. And so what happens is you've got this stool that isn't able to come out, and it leads to back pressure of the stool trapped into the proximal colon. And it's a very important differential diagnosis for chronic constipation as well. So yeah, this is one of the other causes of chronic constipation. So the presentation of Hirschsprung's disease. So it's a delay in passing meconium for more than 48 hours. And you usually will get this distended abdomen and forceful evacuation of meconium after digital rectal examination. That's so important. It's something they might put in the question. It's also common in males, and for children with this condition, it can sometimes lead to chronic history of constipation in their childhood, especially if they've had a poor response to Movicol. It's something you should think that it could be a reason for them to have that poor response to Movicol. And the diagnosis of Hirschsprung's, the gold standard is always rectal suction biopsy. You can do an abdominal X-ray, but rectal suction biopsy is the one that will show you, will essentially show you the aganglionic colon. And the management of Hirschsprung's, initially will do rectal washouts and bowel irrigation, but the definitive management is to remove the section of the aganglionic colon, and this will allow for the healthy bowel to work, essentially. And so question 5. So a 7-year-old presents to the pediatric accident emergency department complaining of pain in my tummy. Father says his son had a sore throat a few days ago. On examination, there is pain in the right iliac fossa, but there is no guarding. Urine dipstick is normal. Which of the following is most likely diagnosis? Is it mesenteric adenitis, Meckel's diverticulum, pyelonephritis, appendicitis, Intussusception? Okay, I'll stop the poll. So with this question we've got, it's between mesenteric adenitis and intussusception. The right response is mesenteric adenitis. So the clue in the question comes from the fact that the son has had a sore throat a few days ago. And he's also got this right iliac fossa pain. There's no guarding, so that's less likely for it to be intussusception. And also, if you've got a sore throat, I think the first thing, and they've got this pain now, first thing to think is mesenteric adenitis is a very common consequence of having the sore throat. So what is mesenteric adenitis? So after having a sore throat, or even during, you can sometimes get inflamed lymph nodes within the mesentery, and this can sometimes cause children to complain of pain in the abdomen, and it can be very similar to appendicitis. So you do need to make sure to rule out appendicitis. Usually, it's quite diffuse abdominal pain, and as we've seen in the context of having an upper respiratory tract infection, they usually will have a low-grade fever, and this tenderness that's generalized throughout the abdominal fields. They might get pharyngitis in the mouth upon examination, and they usually are quite well, apart from having this abdominal pain, and they usually are able to eat still. And this is quite different to appendicitis, where it's more severe. They usually don't have appetite. They usually will feel quite unwell, and their temperatures will be higher as well. In terms of diagnosis, so you could do an ultrasound of the abdomen and you could find these enlarged lymph nodes, and the appendix. You don't always get to see it in ultrasound, but if you can, it will usually appear normal. Yeah, so it doesn't necessarily rule out appendicitis. And then in terms of management, you usually have them stay overnight just to make sure that it isn't appendicitis. And with mesenteric adenitis, it improves spontaneously, whereas appendicitis doesn't. So if they stay overnight, they're not improving, they're getting worse, then you tend to think that it's more likely going to be appendicitis. Next question. I'll open the poll. So a 1-year-old girl presents to ED with intermittent abdominal pain. Her father explains that during these episodes, the child becomes irritable, pale, and draws her legs up towards her abdomen. There has been no vomiting, but the child has refused feeds for 2 days. The abdomen is soft, but there is a palpable sausage-shaped mass in the right flank. Given the likely diagnosis, what is the first-line management after resuscitation? Is it laparotomy, hydrostatic enema, air enema, watch and wait, laparoscopic correction? Is everyone happy with the responses they've made? Yeah. So the correct response is air enema. So with this, it's most likely indicating that the patient has intussusception because of the way the patient is presenting. So intussusception, a bit like gauze, the child will draw their legs up towards their abdomen. They'll be quite irritable, they'll be in quite a lot of pain, and it's intermittent because the abdomen has the colon has peristalsis. So with the peristalsis, when it gets to the point of the intussusception, it will cause pain. And also the other key point to note is the palpable sausage-shaped mass in the right flank. So that's quite indicative of intussusception. And the way to treat this first line is air enema. And that should hopefully, that should hopefully help with the pain. We'll move on to the, oops, sorry. Hopefully you didn't see that. We'll move on to the next question. So we have a 6-month boy who attends on a same-day appointment with their father. Who is worried that over the last 3 days he's been having episodes of inconsolable crying, and again he draws up his legs and he cannot be calmed. You note that his tummy is looking bigger than normal. He's vomited a small amount today. He was also unable to accurately recall if it was a different color than normal. But what is the most likely diagnosis? Yep. So we've got 2 different options from the polls. So it's either it was between intussusception and volvulus. So from the question, the patient, so the correct answer is intussusception. But again, I can see why it's volvulus. But from the question, he's been crying inconsolably, and he's also had his legs up. He draws his legs up, cannot be calmed, and his tummy is looking bigger than normal. That could indicate volvulus, I guess, as well. But in this case, due to the way it's presenting, it's more likely to be intussusception. But with these kinds of questions, you would also, or with these kinds of symptoms, you'd also want to do more investigations just to clarify. So intussusception, so it describes the invagination of the proximal bowel, into the distal segment. So usually it's the ileum passing into the cecum through the ileocecal valve, and its peak ages is between 3 months and 2 years old. It presents with paroxysmal severe colicky pain, and the child characteristically draws up his legs and turns pale. The child recovers, but as this keeps happening, they do become quite tired. And as with the first patient that we saw, they may refuse feeds. Usually, depending on where the site is, they might be bile stains, and a late sign. Quite commonly, they will, in the question, they'll be like, when looking at the Pampers, you'll see that their stool is red currant jelly in appearance and color, but that's quite a late sign, so that's not really a good sign to see. They might also have abdominal distension, and sometimes you might be able to palpate a sausage-shaped mass. I'll show you an image on the next slide, but when you do an abdominal ultrasound, which is what you use to see what's happening, they have this classic target or donut sign, which is these concentric echogenic and hypoechogenic bands, and can also show complications of disease such as free abdominal air or presence of gangrene, which is quite a late sign and quite a severe sign. So you want to try and avoid that. So in the top you can see the free abdominal air within the X-ray, and then in the bottom you can see that target sign. It looks a little bit like a donut as well. Sometimes they describe it like that. So yeah, to investigate, you do ultrasound, and in terms of management, you'll do rectal air insufflation. And if the child is unstable, or the non-operative management, so doing rectal air insufflation doesn't work, or there might be some signs of peritonitis, perforation. So with perforation, you'll get air under the diaphragm. Then, or they're again hemodynamically unstable, you would want to take them to surgery and reduce it in surgery. I hope that makes sense, guys. Next question, 18, we're nearly done. 14-year-old boy presents to ED with sudden onset pain in his lower abdomen and scrotum after being hit by a cricket ball. He has had episodes of pain in the scrotum before, but nothing as bad as this. The pain started around 2 hours ago. On examination, the scrotum is exquisitely tender and swollen, with the left testicle raised higher in the scrotum. What is the most appropriate next step? Is it start IV antibiotics, contact urology for urgent surgical exploration of the scrotum, urgent ultrasound scan of the testicle, urgent abdominal radiograph, refer to urology for outpatients follow-up? So what does everyone think? I'll give you a couple more seconds. Okay, I'll stop the poll. So it's between contact urology for urgent surgical exploration of the scrotum, or urgent Doppler ultrasound scan of the testicle. So, although the correct answer is B, although I can see where you're coming from with C, you want to see what's happening and get an urgent scan. If if they're on examination, the scrotum is very tender and swollen, and then almost always you want to take them to surgery to do an exploration of the scrotum, because it's more likely, especially in this age group, and especially because they've just had an injury with the cricket ball being hit on the scrotum. You straight away want to take them to surgery because it could be testicular torsion. I hope that makes sense. Next question. A 15-year-old boy presents to Pediatric A&E with excruciating groin pain again. It started an hour ago, and since then he's also vomited on one occasion. The patient says he has never had sexual intercourse before. On examination, the right testicle appears swollen and is extremely tender. The Mesenteric reflex is absent on the right side, and elevation causes increase in pain. Which of the following is the most likely diagnosis? So I'll give you a couple of seconds to respond. Yeah, I'll stop the poll. Yeah, correct. It's testicular torsion. So again, look at the age group of the child. He's 15. It's happened quite suddenly. His testicle appears swollen. He's got the Mesenteric reflex is absent, and elevation causes increase in pain. So when you elevate the testicle in epididymitis, if you elevate the testicle, then it will actually cause a decrease in pain. But in this case, it doesn't. And if it causes an increase, then it's more than likely to be testicular torsion. Testicular cancer is less likely to be in this age group, and usually it will be painless. Strangulated inguinal hernia. It could actually be that, but because of how suddenly it's happened and because of the age group, we're leaning towards it being more testicular torsion, and hydrocele wouldn't cause this amount of pain. So yeah, testicular torsion. So what is testicular torsion? It's usually occurs when the testicle is not attached well, when the tissues around the testicle, aren't attached well, and it can cause the testes to twist around the spermatic cord. And when this happens, the testicle actually doesn't have any blood flow, and it is a surgical emergency. And they usually present with this severe pain in one testicle, and it's quite sudden in onset. And as with the first patient, it can occur following a minor trauma. The scrotum will be high riding, so it will be quite elevated, and you'll get this unilateral loss in the cremaster reflex. There's no relief in pain on elevation of the testicle, and this is also known as Friend's sign. It's negative, will be negative. If there is, when you elevate the testicle, if there is a relief in pain, then it's positive, and that is more likely seen in epididymitis. Management, so you want to take them to surgery as soon as possible, and you want to essentially fix the testicle to prevent it from having the testicular torsion. In terms of complications, if you don't take them to surgery and if it's not treated immediately, then obviously there's a lack of blood supply, so the testicle is the testicle's gonna die, it's gonna become necrosed, and it can affect their fertility quite significantly. Next question. Do let me know if there's any questions, by the way. A 2-year-old boy presents to GP with a swelling in the groin. His mother has noticed it in the evenings and when crying. On examination, there is a small painless lump on the right, just above the scrotum. The testicles are normal in size, and the spermatocord is uneasily palpable. There is a cough impulse, and the contents of the lumps are easily reducible. what underlying abnormality. So I'll give you a couple of seconds. Oh, persistent tunica vaginalis, persistence of Mullerian tract, failure of the gubernaculum, patent processus vaginalis, obliterated processus vaginalis. Okay, so we've stopped the poll, and yes, it's patent processus vaginalis. So more often than not, this is quite a common finding in children of that age, and they usually present with this inguinal hernia because of this. And the next question, open the poll. 4-year-old boy is brought into ED by his parents. He started vomiting and complaining of abdominal pain. The pain has come intermittently in the past, but is now acutely worsening. No pain on passing urine was reported. There is generalized tenderness that is worse on palpation in the inguinal region. On palpation, there is a mass in the right inguinal region. The cremasteric reflex is present and Friend's test is negative. The mass is not reducible, and the bowel sounds are heard on auscultation over the mass. What is the most likely diagnosis given this presentation? I'll just give you a couple of seconds. Yeah, I'll stop the poll. So we've got a split between strangulated hernia and acute epididymitis. So with this one, the correct answer is strangulated hernia. The reason for this is when you look at the question, so it's telling you that there is generalized tenderness, worse on palpation in the inguinal region. There's a mass as well in that right inguinal region. And the mass is not reducible. That's really important. If the mass is not reducible, then it's more likely that the hernia is strangulated. Also, when you auscultate that mass, there's bowel styles present, so you know that it's going to be a hernia. With acute epididymitis, firstly, it's less likely to be in this age category. It's more likely to be in someone that's sexually active. It's more likely to come from an STI. So it's less likely to be because of that. I hope that makes sense. So most common hernias in children are congenital inguinal hernias caused by a patent processus vaginalis in babies. And they're mainly right-sided, and they have a high risk for strangulation in the first few months of life. So you would want to do a herniotomy to prevent this risk of strangulation. And the other one is an infantile umbilical hernia. I'll show you images on the next slide. So this is where you have this bulge under the umbilicus, and it's symmetrical. It's quite common in Afro-Caribbean babies and also those with Down syndrome. And strangulation is very rare in these ones, and they usually resolve by the age of 3. So you'd monitor it and see. So yeah, as you can see, you've got the umbilical hernia, and then you have the inguinal hernia here. And as we mentioned, it's quite common for it to be strangulated. So you do want to make sure to keep track of it and make sure that you do a herniotomy if there are any signs of it being strangulated. Next question. So we've got a 2-year-old girl coming to GP with her parents. They have concerns that she is having difficulty growing. She's been feeling tired and lethargic and has had intermittent diarrhea for the past month. In the last 6 months, there has been a drop in 2 centiles for her height and weight. Which of the following would be most appropriate in terms of investigation? So it would be duodenal biopsy, TTG antibodies or total IgA antibodies, endomysial antibody antiglidin antibody, or fecal calprotectin. Okay, I'm going to stop the poll. So the answer is B, but we also got a response for endomesial antibodies. And yeah, so the most appropriate investigation is to do B. And sometimes you do get, there is a small percentage of people that have absence of IgA. So in those instances, you can do an endomesial antibody, but I think it has less specificity, but we'll go into that. So if you move on to question 23, a 12-month-old baby boy is brought to the GP because his mother is concerned he's losing weight. He passes 3 loose stools a day. The stools smell more, and he is generally a much more irritable child than his older sister at the same age. He was weaned from breastfeeding at 6 months and has since had a varied diet of chicken, fish, dairy, cereals, fruit, and vegetables. On questioning his mother, he reports that the loose stools and weight change occurred for about the last 4 months. On inspection, the boy's abdomen is distended, his buttocks are wasted, his abdomen is soft with no hepatosplenomegaly, his temperature is 36.9 degrees. You plot his weight into the growth chart and see that he's dropped from the 60th centile at age 6 months to the 20th for his weight, and similarly for his height. What is the gold standard investigation for diagnosing the child's condition? So is it A, anti-tissue transglutamase antibodies, small bowel biopsy, anti-endomesial antibodies, trial of special exclusion diet, or anti-smooth muscle antibodies? Okay, so I'm going to stop the poll. So we've got between 2 different responses, anti-tissue transglutamase antibodies or trial of special exclusion diet. So the actual answer is small bowel biopsy. And the reason for that is because they ask what is the gold standard investigation. So from the question, we might be able to see that the patient has celiac disease. And with celiac disease, the gold standard is small bowel biopsy. And we'll go into this in a bit. So celiac disease. So this is when a patient has some sensitivity to protein gluten. And with repeated exposure to this gluten, it leads to the villus atrophied, and because of that, it causes malabsorption. Children normally present before the age of 3 years, and commonly it's seen in females. And it's usually after they've been weaned off from breastfeeding, and it's associated with things like they might have a positive family history, they might have the HLA-DQ2 allele, and other autoimmune diseases such as type 1 diabetes mellitus. So they usually come in combination with those. And in terms of the, sorry, I was supposed to say symptoms, not systems. But in terms of the symptoms, they will have this distension, pain in the abdomen, might get some nausea and vomiting, and they'll get this diarrhea or styria. Styria is like it's like fatty, white like stool, very, very smelly. Fatigue, weight loss, usually with the weight loss, failure to thrive. So you'll see that their centiles will be dropping, usually more than 2 drops in the centile is very significant. They might have pallor, again, due to secondary to anemia because they're not able to absorb the iron. They might also get short stature as a result and wasted buttocks. That's quite, you see it quite a lot lot, again, secondary to malnutrition and vitamin deficiency as well. It's not always seen, but you might get, and sometimes it is seen in questions, you might get like dermatitis hepatiformis, and this is essentially these lesions that you get all over your buttocks and extensor surfaces of your arms, legs, and trunks. And it's like a manifestation of celiac, like a dermatological manifestation of celiac disease. In terms of diagnostic tests, so you will usually do a stool culture to exclude infection, but the gold standard is to do a biopsy. And you would usually tell the parents to not withdraw gluten from the diet, which I know might appear a bit evil, but if you take the gluten out of the diet, then you won't be able to see the histological results. So you won't be able to see the atrophy, the crypt hyperplasia, or the intraepithelial lymphocytes. So you won't be able to see any of those present, and you won't be able to diagnose the patient. You can also do blood tests. So the first line is anti-TGG, IgA antibody. That's like the main one, but sometimes celiac disease patients will be deficient in this. So you can do an anti-TTG IgG, or you can do the anti-endometrial antibody, but again, it's less specific. It's more specific, sorry, but less sensitive. And antiglidin is not recommended by NICE at all. In terms of management, it's lifelong gluten-free diet. And you need to have regular monitoring to check for adherence to that gluten diet and screen for any complications. And in terms of complications, they might have anemia, they might get hyposplenism, and because of that, they are more susceptible to getting encapsulated infections by encapsulated organisms. So you want to make sure that they get vaccinated for pneumonia. I think it's pneumonia. I'll double check that. And then osteoporosis is another one. Again, because they're not getting the absorption of nutrients. And then enteropathy associated T cell lymphoma. So it's quite rare type of non-Hodgkin's lymphoma, but it can occur in these patients. And interestingly, it's dependent on patients' adherence to gluten diet. Last question. So I'll just put on the poll. A mother brings in her 9-year-old son to GP saying he has been feeling unwell with a fever for the past 24 hours. She reports he had tummy pain all day yesterday and vomited last night and refused to eat breakfast this morning. He is drinking normally and passing urine and has had 1 episode of loose stools today, which does not contain blood. On examination, the patient is pale. Abdominal examination also reveals generalized tenderness and with guarding and tenderness to percussion. Genital examination is unremarkable. Urine dipstick is normal. His observations are heart rate of 130, blood pressure 80/50, and oxygen saturation of 98% on air. Which of the following is most likely diagnosis? Is it pyloric stenosis, appendicitis, mesenteric adenitis, testicular torsion, or UTI? Sorry, for some reason the poll stopped working. I'm just going to try reload it. Yeah, there you go. So I'll give you guys some time to answer that. Okay, I'll stop the poll. And we've got appendicitis as the most common response. And yes, that's correct. It is appendicitis. So the clue comes from the fact that he's been having this tummy pain, also that he's vomited. It's less likely for them to vomit quite frequently, but to have nausea and to vomit at least once is quite common. He's not had any issues with his urine. That's rules out UTI, and he's had one episode of loose stools today. There's quite a lot of significant tenderness and guarding as well, so that indicates that he's got appendicitis. So most common acute abdomen presentation that requires surgery is appendicitis, and usually it starts from the periumbilical area and it radiates to the right iliac fossa. Again, this is the most usual way it presents, but again, this might not be the case for all patients. Pain will get worse on coughing as well. So you get these common features. You might get nausea and vomiting. You'll get temperature, usually in those ranges, and you might also get anorexia, so the patient will not want to eat at all. On examination, if perforation has occurred, they might get this generalized peritonitis, which this patient might have. So you might get Rosving's sign, so palpation of the left iliac fossa, so on the opposite side, will cause pain in the right iliac fossa. But you don't, now it's not really used as much. And then you've also got psoas sign, so pain on extending hip. You will see that mainly if you get retrocecal appendix. So the appendix actually can be found in many different positions, and if it's retrocecal, then they might get pain when you extend their hip, and that's known as the psoas sign. In terms of diagnosis and management, so you diagnose it with raised inflammatory markers and neutrophil predominant leukocytosis, and you can sometimes use an ultrasound. Again, you might not be able to find the appendix, so you do have to have a low suspicion to treatment for this, because you really don't want it to perforate, as once it perforates, it's not got the best prognosis, and it can be quite difficult for the patient itself. In terms of management is mainly appendectomy, and you might also give prophylactic IV antibiotics. This is being used more and more, especially in adults. They sometimes just give them IV antibiotics, and that can sometimes prevent them from having an appendectomy. But more commonly in children and still in adults, you will still do an appendectomy. And if perforated, it requires extensive abdominal lavage. And I think that takes us to the end. Does anyone have any questions? Thank you for listening and paying attention for this time. I do hope it was useful.
Thank you so much, Valentina, and thank you everyone for coming. Please do fill in the feedback form, and if you're watching online, please also, Valentina, do you mind popping that slide up again? Just so if you're online, they can. Just saying, even if you're watching on YouTube, please fill in the feedback form, because we leave it open for a long time, and more of you are now just watching the videos, which is fine, but it's just really useful for us to have some feedback and just know how it's going, and for our speakers to know how it's gone as well. So please fill it in. But yeah, thank you very much for today.